Hello everyone. So let's get started with the abdominal viscera. So the first viscera that we are going to deal is with stomach. A very important university essay question. Of course, a very important clinical topic also. So if it is asked as an essay, what are the side headings under which you will cover? Yes, you have to start by giving the location. So you all know the abdomen has got, or it is being divided into 9 quadrants. So any viscera you take, you're supposed to locate the organ with respect to those 9 quadrants, followed by the external features and the parts, relations. Interior of the stomach is very important, followed by blood supply, nerve supply, lymphatic drainage. Yes, so lymphatic drainage is a separate short note, blood supply is a separate short note, and all these headings can be a part of essay question. So let us get started. So with the location, so these are the 9 quadrants of the abdomen. So just to quickly note all the 9 quadrants, as this is your right hypochondric, this is left hypochondric, right? This is right lumbar, left lumbar. This is right iliac, this is left iliac. And this one is your epigastric, right? So that region is your epigastric region. And this one is your umbilical region. And this one is your hypogastric region, right? So these are the 9 quadrants of the abdomen. Now, if you take the stomach is going to extend from the left hypochondrium to the umbilical region. Can you appreciate this? This is the organ. So if you take, it extends from the left hypochondric to the umbilical region. So it extends from the left hypochondric to the umbilical region, and it also shares some part with the epigastric. So location, yes, it is related, as I said, and also it is related to some parts of the epigastric region. So these are the 3 quadrants of abdomen where the stomach is related, right? So this is its location. The next one is the external feature. So if you take the external feature, we are going to have rule of 2's. Okay, this is my own rule. So you have got 2 ends, then you have got 2 surfaces, 2 curvatures. So if the organ is given to you, what are the external features that you appreciate? Is you appreciate 2 ends, 2 surfaces, and then 2 curvatures. Yes, so what are the 2 ends? You have got the cardiac end. Yes, you have got the cardiac end and the pyloric end. So these are the 2 ends. Then what are the 2 curvatures? Yes, you have got a lesser curvature and you have got a greater curvature. So on the lateral aspect, you have got a short concave course. Yes, can you make out this entire thing? So let me use a pointer. This one, right? So this short lateral border, which is concave in shape, this is your lesser curvature. Whereas if you take the long convex surface or the long convex curvature that you have is your greater curvature. So I have got 2 curvatures, I have got 2 ends. So this is my cardiac end and this is my pyloric end. And I have got 2 surfaces, that is the antero-superior surface and the postero-inferior surface. So you have got an anterior surface and a posterior surface. Yes, so 2 ends, 2 surfaces and 2 curvatures. You can just include 1 or 2 points about it. So lesser curvature is the the lateral short concave border. Greater curvature is the long convex border, right? So this is the long convex border. This is lateral short concave aspect, right? So that is your lesser curvature. So these are some of the points that you must include with respect to external features. Now, what are the parts? Yes, first we have seen the external features. Now, what are the parts of the stomach? As you have got 4 important parts: fundus, body, pylorus, and the first part is your cardiac part. Yes, you have the 4 parts, right? So cardiac part, fundus, body, and then your pylorus. Now, we have to see certain things here. So if you take, you have got 2 notch also. Let me include another word, 2 notch. So this one that we see here is your cardiac notch, right? So this notch, what is the role of this notch? Notch is basically like a depression, right? So this notch is going to separate, esophagus from the greater curvature of the stomach, right? So here you have got the cardiac notch and this is your esophagus and this is your greater curvature of the stomach. So these two structures are separated by the cardiac notch. And here you have got another notch along the lesser curvature, that is your angular notch. And this angular notch is going to mark the fusion of the body and the pylorus, right? So this is the body of the stomach. If you appreciate this is the body of your stomach and this is your pylorus. So here I am going to have a notch, and that notch is called as your angular notch, right? So this is about the two notches that are also present, right? So now if you take the cardiac part, yes, you have got the fundus. What is most important about fundus is, yes, this is going to be related to the fifth intercostal space. What is present in the fourth intercostal space? Yes, if you remember the very first video of 2021 𝗵𝗵𝗂𝒂𝗃 breast, it was taken by me, right? There we would have talked about the nipple. So nipple is going to lie along the fourth intercostal space, and in the fifth intercostal space we have got the fundus. So what is more important, or why we are stressing upon the location of fundus is, if there is any gastric irritation or any gastric pathology, then the pain is referred to chest. So that we call it as angina pectoris, right? Angina pectoris. So any pathology in the fundus of the stomach is going to be reflected over the cardiac region, because the fundus directly lies on the fifth intercostal space, right? And you have got body, and then you have got pylorus. So if you take pylorus, you have got three parts. One is your pyloric antrum, next one is your pyloric canal, the next one itself is the pylorus. So this is the pyloric part, which in turn contains three: pyloric antrum, pyloric canal, and the pylorus. So if you take the these are the parts, right? So you do not have much points to include here. So what you have to know is the pyloric region is more susceptible. It is more susceptible for carcinoma stomach, right? And it is also the most common place for irritation, right? Ulcerations are all more common in the pyloric region, right? So this much you have to know. So you have got three parts, yes, antrum, then canal, and the pylorus. And as I said, this region is more prone for CA stomach. And if you take pylorus, this is what is going to represent the sphincter. So it is going to guard the movement of substances from the stomach into the duodenum, right? So this is about the different parts of the stomach. Just try to draw this diagram, name, and write few points that I have discussed here, right? So not that very important, yes, but you have to know, right? Now, next important topic is your relations, right? So far we have just seen a very small introduction that we all are learning right from our +1, right? So I did not touch upon much of the details because everything is already known facts. Now let us get to our exact anatomy, that is relations of stomach, right? So whenever we talk about an organ, we have to talk about two relations. Please do not forget to include these two relations. The first one is your peritoneal relations. So how the organ is related to the peritoneum, or how the peritoneum is going to extend from this viscera. Yes, that is your peritoneal relation. The second one is the visceral relation. So whenever we discuss any viscera, we have to include these two relations. Yes. So the peritoneum is going to cover the entire stomach. What it is going to do? The peritoneum, it covers the entire walls of the stomach. Yes, it covers the entire walls of the stomach, except where? Except the the passage along the curvatures. If you take the lesser curvature and the greater curvature, you will have the blood vessels that are passing there, right? So except at the site of passage of blood vessels, yes, and a very important one, that is bare area of stomach. So bare meaning what? Empty, right? So on the posterior aspect of the cardiac part, so if you remember the parts, as we saw, this is the cardiac part, right? So on the posterior aspect of the cardiac part, we have got a region where we do not have any peritoneum at all. That is called bare area of the stomach. This is also an important MCQ question. They can ask you the relation of the bare area. Right? Listen carefully. Yes, first question possible is location of bare area. It is located on the posterior aspect. Yes, it is located on the posterior aspect of the cardiac part of the stomach. Yes, very good. The next point is how it is related, right? So the bare area of the stomach, very important. It is related to the left crust of the diaphragm. So you have got a left crust, right crust and all that, right? So it is related to the left crura or the left crust of the diaphragm. So these are the 2 points that you must know with respect to bare area of the stomach, right? Now, next the peritoneum. So how the peritoneum is going to extend from the stomach. So you all know we have got 2 curvatures. Yes, this one is your lesser curvature and this one is your greater curvature, right? So along the lesser curvature, if you take the peritoneum is going to extend from the lesser curvature. Listen carefully, it extends from the lesser curvature and it gets to the liver, right? So there is a peritoneal modification that connects the lesser curvature of the stomach to the liver. That one is called as lesser omentum. So along the lesser curvature, you have got only one peritoneal fold that is called lesser omentum. This omentum is going to connect which 2 structures? It connects or it establishes a connection between the lesser curvature of the stomach with that of the liver. Right? So I've got 2 parts, the hepatogastric, which means it arises from the stomach, gets to the liver, and from the duodenum. Right? So just know this. It's not that important, but just know lesser omentum, it has got 2 parts, right? But along the greater curvature, if you take, we have got 3 important structures. One, of course, if you have a lesser omentum, you should definitely have the greater omentum, right? So almost if you take, you would have studied in the peritoneal folds. In the previous video, they would have told you about greater omentum, the policeman of the abdomen, it has got so many macrophages, all these stories, right? So if you take the greater omentum, again, almost the lower part of the greater curvature, right? So almost the lower aspect of the greater curvature, you have got a peritoneal fold that extends all along. So that one is called as your greater omentum. Then you have got 2 other relations, that is the gastrosplenic, gastrophrenic ligament. So that is a peritoneal membrane or the peritoneal fold that extends from the stomach or from the greater curvature to the spleen. So that ligament is called as gastrosplenic ligament. Yes, there is some part of the greater curvature. It establishes a connection through this peritoneum with that of the diaphragm. As this is the fundus, so it is related to the diaphragm. We saw it is related to the 5th intercostal space, right? So it is almost related to the diaphragm also. So there is a connection between the greater curvature of the stomach and that of the diaphragm. So if you take the peritoneal relations along the lesser curvature, as you have got something called as lesser omentum. Then along the greater curvature, you have got 3 G's, right? Just remember 3 G's. One is the greater omentum. Next is the gastrosplenic ligament. Next is the gastrophrenic ligament. So these are the peritoneal relations. I hope I am clear. The next one is your visceral relations. So when it comes to visceral relation, it is our duty to talk about the viscera on all the surfaces of the viscera. Right now, if you take stomach, yes, how many surfaces we have got? We have got 2 surfaces. One is your anterior surface or the anterosuperior. Another one is the posterior or the postero-inferior surface, right? So I'll write it as superior and inferior so that you will not get confused. Anterosuperior or the anterior surface, the posterior or the postero-inferior surface. So the picture that I am putting here is related to the anterior relations. It is related to the anterior relations. So if you take this picture as given all the details that you must know, he has told that the stomach is related to some area of the liver, it is related to some part of the diaphragm, it is related to some aspect of the anterior abdominal wall. It's very simply same thing. So if you take, it is related to some part of the liver. So tomorrow's class will be on liver, where they'll be talking about different lobes of liver and all that. So the liver has got so many lobes, right? So mainly if you take the anterior surface of the stomach, the anterior surface of the stomach is related to the left lobe of the liver and something called as the quadrate lobe of the liver, right? Left lobe of the liver and the quadrate lobe of the liver. So these are the 2 relations with respect to liver. So the stomach is related, the anterior surface of the stomach is related to 2 aspects of liver. One is the left lobe of the liver, another one is the quadrate lobe of the liver. Right? It is related to the quadrate lobe of the liver. So quadrate lobe, if you take, it will be somewhere here. Okay, so if you take, this is the pylorus. So the pylorus of the stomach is related to the quadrate lobe. And if you take the body and the cardiac and the fundus part, they are related to the left lobe of the liver. So here you'll be having the left lobe and here you'll be having the quadrate lobe. So the quadrate lobe is related to the pylorus of the stomach, whereas the left lobe is related to the body and the fundus of the stomach. Yes. Next is the diaphragm. So he has given the area related to diaphragm. So diaphragm and the associated rib cage, right? Then the area related to the anterior abdominal wall. So this is the relation of the anterior surface of the stomach. So you just, this is all imaginary, right? So if you know the location of stomach. So if you take the very first picture, yes, this is the stomach. So here you all know you'll be having liver, and here you are having diaphragm, right? And you are having rib cages. So it is associated with the rib cage, the diaphragm, and here you have got the liver. And here if you take here, all these are part of the anterior abdominal wall. So it is related to the liver, it is related to the rib cage and diaphragm, it is related to the anterior abdominal wall. Right, everything is in black, so I hope you will not be able to make out. But yes, with this picture, you will be able to come to a conclusion, right? So this is about the anterior relations of the liver. Now coming on to the posterior relation. So the posterior relations are collectively called as stomach bed. So if you take, this looks like bed, right? This entire structures look like bed where the stomach is going to take rest. Can you appreciate this? This dotted line is the stomach, and if you take it is just relaxing, right? So that is why it is called as stomach bed. So the posterior relations have got so many visceras, and there is an acronym to remember. Dr. S3 kills patient mercilessly. So maybe you would have attended online classes. So he is not a knowledgeable doctor, so he is going to kill the patient just like that, without any mercy. He kills patient. So Dr. S3 kills patient mercilessly. So the first letter of all these, so D, then you have got S3. So we are going to see three structures that starts with S, then K, P, M. So all these organs starting with all these are going to form the posterior relation of the stomach or the stomach bed. So what does P stand for? The P, sorry, first one is D, right? So D stands for diaphragm. So if you appreciate this picture here, if you take, yes, the fundus of the stomach is related to the diaphragm. And if you take diaphragm, we'll try to extend on the posterior aspect also. Even when you talk about liver tomorrow, we'll be talking about diaphragm in the posterior aspect, right? So the diaphragm, as it is going to also extend posteriorly to a certain extent. So one is the diaphragm. Then you have got S3. So we are going to talk about 3S. So what are the S that I am able to appreciate from this picture? Yes, you have got spleen, you have got suprarenal gland, left suprarenal gland, and the splenic artery. Right? So spleen, splenic artery, and the left suprarenal gland, they are the 3S that forms the stomach bed. Yes, they form the stomach bed. K for kidney. Right, so if you appreciate, whenever I talk about suprarenal gland, obviously kidney will come, right? So this is the spleen, and here if you take, this is my kidney and this is the suprarenal gland. So suprarenal gland, spleen, the splenic artery, the kidney, all these are going to form the stomach bed. S. P for pancreas, right? So if you take here, you have got the pancreas. Then M for mesocolon, transverse mesocolon. S, can you appreciate here? You have got the transverse mesocolon. So the posterior relations or the stomach bed is formed by Dr. S3 kills patient mercilessly, that is diaphragm, spleen, suprarenal gland, splenic artery, kidney, pancreas, and the transverse mesocolon. So these are the posterior relations. So when it comes to relation, is do not forget to include the peritoneal relations. And whenever you talk about peritoneal relation with respect to stomach and the liver, do not forget to include about bare area has got an utmost importance. Even it can be a spotter. And bare area of the liver is a very important spotter, right? So bare area is very important. Followed by your visceral relations, you have got the anterior relation, you have got the posterior relation, and the posterior surface relation is what I refer to as stomach bed. Is very clear. Now talking about interior. Interior, I have not included the histological aspect because you all know any GIT has got 4 layers. Right, serosa, muscularis, submucosa, and the mucosa. So that you have to write, and you have to mention about the gastric glands, the parietal, the oxyntic glands, all that has to be mentioned under histology. Now we are going to talk only about the interior of the stomach. The moment you hear the word interior of the stomach, you have to remember three things. Or the most important thing that you want to remember is the gastric rugae. Utmost importance, right? So if you take what happens, the mucosal fold. So you all know the mucosa is the interior aspect of the stomach. The mucosa is going to undergo certain foldings. It is going to undergo some infoldings, the modifications, right? So those are called as the gastric rugae. Why basically should have folds is probably to increase the surface area. Okay, so that there is complete digestion and all that. So for basically for the surface area, the mucosa has been thrown into so many folds, right? So the mucosal folds that are present in the interior of the stomach is called as gastric rugae or the gastric folds, right? If you take, there is some variation. Can you appreciate closer to the lesser curvature, you have not got gastric folds at all. And here if you take, you have got a more longitudinal folds, right? So if you take, these are all longitudinal. Here you take, they are very irregular. Can you appreciate this portion? Just appreciate this portion. Here it is irregular. Whereas if you take here, they are very regular, like they are longitudinal, right? So if you appreciate all these are longitudinal folds. Yes, the gastric fold shows some partiality. What partiality? Yes, close to the lesser curvature of the stomach, right? Close to the lesser curvature, you have got longitudinal folds. But as it gets to the interior aspect, it becomes very irregular. It becomes very irregular. So that is the point that you must include. Okay, so with respect to gastric rugae. The second one, can you appreciate some dots like puttu-like structures here? All these small dots. All these dots are called as gastric pits. So in the gastric rugae, if you take, there is some pit-like structure or a depression that is formed. Why there should be a depression is for the gastric glands. So the gastric glands are going to be present there, so which throws its secretion into these gastric pits. Right, so the glands are lodged into these pits. So you have got the folds that are longitudinal along the side of the lesser curvature, but towards the greater curvature or the interior aspect, it becomes irregular. And in the gastric rugae, I'm able to appreciate some pits called as gastric pits, which has lodged the gastric glands. So all these secretions are poured there. Another important structure that you must know is the gastric canal. This is not a permanent structure, but it is a temporary structure. So temporary means it is going to form under a condition. So when that condition is going to exist, then the structure is going to be formed. So what is that condition? Is when a person is consuming his food, right? When he is swallowing, what happens? This gastric canal is going to form. So along the length of the lesser curvature, a canal is formed, right, which allows the substances to directly jump into the pylorus. Right, so suppose we give some irritant substance, right? If we give irritant substance, if it is going to get exposed to the entire part of the stomach, then it is very dangerous, right? So as a protective mechanism, when a patient or when a person is swallowing his food, the stomach is going to ensure that a canal is formed that is not going to allow the exposure of that substance to the entire musculature. Able to get that? Yes. So if you take alcohol or any ulcerative substances, the most common site of injury is going to be along the lesser curvature, along the pylorus, right? So why pylorus is most damaged? Because it gets exposed at a very high rate, and even along the walls of the gastric canal or the lesser curvature, right? So when interior comes, very important thing is the gastric rugae or the folds, then gastric pits, then the gastric canal. So mostly, patient who consumes lots of alcohol, he takes lots of spice. So the damage, because of all these substances are mostly seen in the region along the lesser curvature or along the pylorus. Yes, that is the importance of knowing this temporary construction of the stomach, which includes gastric canal, right? Yes, done. So if you take this is the gross picture, so here you are able to appreciate loss of rugae, right? So here if you take it is bit longitudinal, and here if you take it is more irregular, and you will be able to appreciate some pits. I'm not able to show you any pit here. Yes, so somewhere here you will be having some pits, right? So where the gastric glands are going to be lodged, right? So this is the gross picture that I want to show you. because again this is a spotter, they can have it for discussion, right? Next, coming on to blood supply, right? Blood supply, I have scheduled it as a separate topic. We'll be talking about the abdominal aorta, the celiac trunk, which is going to be from the abdominal aorta. So we have got a detailed class on blood supply. So then and there we'll just try to study these blood supply so that you can know, integrate everything when that session comes. So you'll be able to understand the blood supply of the abdomen very clearly if you know, try to understand the blood supply of every organ then and there, right? Yes. Now, what are the major arteries that you must focus? You have to focus on right gastric artery, then the left gastric artery, right gastroepiploic, left gastroepiploic, short gastric arteries. These are the 5 arteries to which your eyes should go. Yes. 1, 2, 3, 4, 5. Never mind, I've got a bad throat. Now, first one is your right gastric artery. Let us trace the right gastric artery. Yes. So if you take right gastric artery, it is here. And if you are able to appreciate it as it is coming from a principal artery. What is this principal artery? Yes, it is hepatic artery. So the first blood supply that we can write is the right gastric artery, which is a branch of hepatic artery. If you're going to give this detail, it is more than enough. If it is asked as a short note, also draw this diagram, just mention right gastric artery, branch of hepatic artery. Next that I highlighted was left gastric artery. Yes, so left gastric artery. So if you trace left gastric artery, yes, it is coming directly from the trunk. So this is my celiac trunk. And if you appreciate, you have got an artery called left gastric artery. So it is a direct branch of celiac trunk. So these are the first sets of arteries, right? So if you take the right gastric artery and the left gastric artery are forming an anastomosis. Can you appreciate this? They are forming an anastomosis along the lesser curvature. So the blood supply to the lesser curvature is by these 2 gastric arteries, that is the right gastric artery and the left gastric artery. Right from the hepatic, left from the celiac trunk. Now the next set of arteries, yes, we saw gastroepiploic. The right gastroepiploic, the left gastroepiploic. Let us write the name. Right gastroepiploic, then left gastroepiploic. Yes. So where is this right gastroepiploic? So if you take the right gastroepiploic artery, is coming from gastroduodenal artery, right? So right gastroepiploic artery is a branch of gastroduodenal artery. So if you take the gastroduodenal artery, will give rise to 2 branches. If you take the superior pancreatico-duodenal artery and the right gastroepiploic artery. So the pancreatico-duodenal will supply the duodenum and the pancreas, and the right gastroepiploic artery is going to supply the greater curvature of the stomach. So it is a branch of gastroduodenal artery. Yes. Now, if you take the left gastroepiploic artery, this is the spleen, and from the celiac trunk we have got the splenic artery that comes. So the splenic artery is going to give rise to left gastroepiploic artery. So left gastroepiploic is a branch of splenic artery. Splenic artery in turn is a branch of celiac trunk. Yes, very good, done. The last one, if you take, is we have got something here, right? Short gastric arteries. Short gastric artery. Again, it is a branch of splenic artery. So if you appreciate this, you have got some minute branches that supply the body and the fundus of the stomach. So that is short gastric arteries. So again, if you take the right gastroepiploic and the left gastroepiploic arteries are going to form an anastomosis around the greater curvature, right? So these 2 are forming an anastomosis around greater curvature, right? Just now I wrote short gastric, it disappeared somehow, right? Short gastric is a branch of splenic artery, right? So this is about the blood supply. So when the blood supply is asked, yes, you have to highlight the celiac trunk, you have to highlight the hepatic artery. So from the celiac trunk, yes, you have got the left gastric artery, splenic artery. Splenic artery in turn gives rise to the left gastroepiploic and the short gastric artery. Then if you take, you have got the right gastroepiploic artery, which is going to come from the gastroduodenal artery, and the right gastric artery that comes from the hepatic artery. Right? Yes, so these are the blood supply. Now coming to, so whenever we talk about blood supply, yes, we have to talk about arterial supply as well as venous drainage. Yes, we have to talk about arterial supply and then venous drainage. Right, so if you take, it is going to come under the same names, the left gastric vein, like it is going to take the names of the arteries. Left gastric artery is left gastric vein, right gastric artery is right gastric vein, then gastroepiploic veins, then you have got the splenic veins, right? Sorry, you have got the short gastric veins. So if you take, yes, you have got left gastric vein, then you have got right gastric vein. So the left gastric vein, right gastric vein, it is going to follow the course of the respective arteries, as it is going to drain the venous blood from the lesser curvature. So it drains the blood and it is going to give it to which vein? It is going to give to portal vein. So the right gastric vein, left gastric vein, they take all the venous blood and they drain into portal vein. So whenever you write the venous drainage, you have to write the name of the vein and where it drains to, right? So the right gastric vein and the left gastric vein, they drain into portal vein. Yes, they drain into portal vein. Now if you take the right gastroepiploic, yes, it is going to cover certain aspects of greater curvature and it drains into, yes, it drains into the superior mesenteric vein. It is going to follow the, no, again, superior mesenteric vein will be studying in pancreas. It is going to form a relation of with pancreas, right? So the superior mesenteric vein is going to be drained by the right gastroepiploic vein. So the right gastroepiploic vein drains all the venous blood from the aspects of the greater curvature into the superior mesenteric vein. The left gastroepiploic and the short gastric veins, it is going to drain into the splenic veins. It is going to drain into the splenic veins. Right, so left gastric, right gastric into portal vein, right gastroepiploic into superior mesenteric, left gastroepiploic and the short gastric veins into the splenic veins. Right, clear? Yes, very good. Next, lymphatic drainage. As I said, a very important short note, very important clinicals. Right, now if you take the lymphatic drainage, for our convenience, like how we studied in breast, right, we divide into 4 quadrants and we studied. Similarly here we divide into 4 quadrants, but it is not an equal stuff. Okay, it is not actually a quadrant, I can say 4 parts. So how they divide the stomach is, first we add an horizontal line, right? It's not horizontal, but almost I can say along the long axis of the stomach, we made a line. So I divided the stomach into the lateral 2/3. So if your lesser curvature is along the lateral aspect, right? So no, along the, no, I can say it has been divided into 2/3 and the 1/3. Sorry, medial 2/3 and the lateral 1/3. So this is the greater curvature, this is lateral aspect, this is the medial aspect. I'm sorry. So it has been divided into 2/3, right, and the 1/3. So by this long axis, right, then we add 2 horizontal sections on the respective parts, right? So this 2/3 was divided into upper and the lower by means of an horizontal thing. And similarly, if you take here, it was divided into 2 parts. So totally, the lymphatic drainage of the stomach was studied under 4 areas: area 1, area 2, area 3, and area 4. So area 1, if you take S, this is the area 1, right? So cardiac part, some part of the body, right? So all the lymph from the area 1, it drains into the left gastric nodes. So if we saw left gastric artery, left gastric vein, now see left gastric nodes, right? So from the area 1, the lymph is drained into the left gastric nodes. From the left gastric nodes, it gets to the principal vessel, that is your celiac nodes. Yes, so this is the lymphatic drainage about the part 1. Now if you take the part 2, right, it is going to be drained by the right gastroepiploic nodes. So you have got some parts of the body and also the pyloric area. So the pyloric area has been divided. So some lymph from the pylorus will enter into right gastroepiploic nodes and some will get into the pyloric nodes, right? So if you take the area 2 has got right gastroepiploic nodes and the pyloric nodes, right? And if you take the pylorus region, as I told in the very beginning, it is the most common site for the carcinoma stomach. It's very important that the pylorus is the most irritated region and it is the most common site for the no origin of the carcinoma stomach. So the area 2 along the greater curvature, it is drained by the right gastroepiploic nodes, and majority of the lymph from the pylorus region drains the lymph into the pyloric nodes. Area 3, yes, it drains into the pancreatico-splenic nodes. Area 4, if you take area 4, some parts, okay, some of the lymph will drain into the right gastric nodes. So along the lesser curvature, almost slightly distal. So here we'll be having an angular notch. So distal to the angular notch. So this is my angular notch, right? So distal to the angular notch, the lymph is drained by the right gastric nodes. And somewhere close to the pylorus region, the lymph is drained to the hepatic nodes. So some amount of the lymph gets to the right gastric nodes, some amount it gets into the hepatic nodes, right? And whatever lymph is going to be drained by the pyloric nodes, again it communicates to the hepatic nodes. From the hepatic nodes, it gets to the celiac nodes, right? So if you want me to summarize, yes, you have got left gastric nodes, which is from the area 1. Area 2 is going to drain from the right gastroepiploic, and you have got pyloric nodes. Yes, that is area 2. Area 3 is the pancreatico-splenic nodes. Area 4, if you take, you have got right gastric and directly into the hepatic nodes, right? So the lymph from the pyloric nodes, which is related to the part 2, also sends its lymph to the hepatic nodes. So finally, all the lymph collected from the stomach is going to drain into the celiac nodes, and from the celiac nodes, it enters cisterna chyli. It enters cisterna chyli. Very important, right? Very simple lymphatic drainage. Do not have any complications. Even though I would say breast lymphatic drainage is a bit complicated when compared to stomach, right? It's very simple, but a very important thing. Why it is important? Because as usual, when I talk about carcinoma, I told in the breast itself have got two routes of spread. One through the bloodstream. Another one is to the lymphatic spread. Lymphatic spread is very common, right? So what happens? Can you appreciate what is happening here? Yes, you have got a swelling. Yes, you have got a swelling. What happens is the carcinoma arising from the stomach or from the pylorus part of the stomach is going to communicate with the left supraclavicular lymph node. Right? Like how we saw in the breast is from the medial quadrant through the subperitoneal lymph plexus, it got into ovary. Right? Similarly, from the stomach, the cancerous cell is going to spread to the left supraclavicular lymph node. This left supraclavicular lymph node, which is involved in the pathology of the carcinoma of stomach, is called as Virchow's node. It is called as Virchow node. What is Virchow node? The left supraclavicular lymph node, which is usually involved in the carcinoma of the stomach, is called as the Virchow node. So when the Virchow's node is involved, the node is going to be excessively infiltrated with the cancerous cell. So the node is going to swell. So this, if you take, it is the swelling of the Virchow's node. This is called as Troyer's sign. It is called as Troyer's sign. Right? So Virchow's node, Troyer's. You have got some, just be very careful. You have got something called as Troyer's sign also. Right? Troyer's sign, SSIERS is different, SERS is different. Please do not confuse between these two. Be very careful with the spelling, right? So Troyer's sign is actually the involvement of the Virchow's node, which is presented as a neck swelling, right? So whenever a patient has got carcinoma stomach, the cancerous cell through lymphatic spread can reach the Virchow's node, and there is swelling of the Virchow's node. That is called Troyer's sign. So if you want to know about Troyer's sign, you have to know about Virchow node. If you want to know about Virchow node, you have to know about the lymphatic drainage of the stomach. Yes. So only if you know all these, you can probably think of CA stomach, right? So just see how it goes, right? So it is very important. Yes. So I hope you are clear with the lymphatic drainage. This diagram should be drawn if it is asked in the exams. Now supply is very simple. You have got sympathetic, like how we have to include the arterial supply and venous drainage for blood supply. You have to include both sympathetic and parasympathetic for nerve supply. So sympathetic, if you take, yes, it is derived from T6 to T10 spinal segments. That is, yes, it is derived from T6 to T10 spinal segments, right? So it is going to be mainly a vasomotor. So it is going to supply the pyloric sphincter, and then if you take, it is going to carry all the pain sensation from the stomach. It is going to carry pain sensation. So the sympathetic is mainly vasomotor, then it has got pain sensation, and it is also going to send some motor routes to the pyloric sphincter. So these are the three functions of the sympathetic supply of the stomach. Yes. Now parasympathetic, yes, I'm going to explain you only with this picture. Listen carefully. Parasympathetic, yes, you all know it is from the vagus nerve, right? So you have got two vagus nerve, the left vagus nerve and the right vagus nerve. The left vagus nerve, yes, the left vagus nerve is going to pass along the anterior aspect of the esophagus. So if you take, this is the esophagus, the lower part of the esophagus. So the left vagus nerve is going to pass anteriorly along the esophagus. So it is called as the anterior vagal trunk. It is called as the anterior vagal trunk. Whereas the right vagus is going to pass posteriorly to the esophagus. So that is called as the posterior vagal trunk. So I've got two vagus nerve, left vagus, right vagus. Left vagus is going to go along the anterior aspect of the esophagus and the stomach, and the posterior, that is the right vagus, is going to go along the posterior aspect of the stomach. Yes. So let's see what happens to each of these vagal trunks. Now, it enters, right? So from the esophagus, yes, this is the gastroesophageal junction. So at the gastroesophageal junction, it gives rise to certain branches. Yes, what are the branches? Can you appreciate? The first one is the hepatic branch. The first one is your hepatic branch. So if you take the hepatic branch, yes, it arises at the gastroesophageal junction, right? So what is this? Yes, this is the lesser curvature, an hepatic branch, which means it is going to get to the liver, right? So the nerve is going to go along the lesser omentum. You all know when we spoke about the peritoneum, we saw along the lesser curvature, you had only one peritoneal relation, that is your lesser omentum, right? It's extended from the stomach to the liver, right? So the nerve, yes, the hepatic branch of the anterior vagal nerve is going to go along the lesser omentum, and it supplies the liver and the gallbladder. It supplies the liver and the gallbladder. Then you have got the celiac branch, which supplies the celiac plexus. You've got a network around the celiac trunk, that is the celiac plexus. So the celiac branch is going to go and supply the celiac plexus. And if you take, you have got something called as the gastric branch or the nerve of Latterjet. Right, you have got, this is the anterior nerve of Latterjet, and similarly if you take here, you have got the posterior nerve of Latterjet. So this anterior nerve of Latterjet is the one that is going to supply the body and the pylorus of the stomach. So far we were talking about the exterior, right? So the hepatic branch supplies the liver, the celiac branch supplies the celiac plexus. So what is actually supplying the stomach? Yes, it is the anterior nerve of the Latterjet that supplies the body and the pylorus of the stomach. Yes. Now similarly, if you take posterior vagal trunk, you have got something called celiac branch, again which is going to supply the celiac ganglion along the celiac plexus. Yes, this is number one. Number two is something called nerve of Grassi. Very important. Now if you take the anterior nerve of Latterjet, we saw it supplies the anterior aspect of the body and the pylorus of the stomach. Then what did fundus do? We saw fundus is very important because the pain over or any irritation over the fundus is reflected to the diaphragm. So fundus is very important. So it has to be supplied by something. Yes. So the nerve that supplies the fundus of the stomach is the nerve of Grassi, which arises from the posterior vagal trunk. Right. Then we have got nerve of Latterjet, which supplies the posterior aspect of the body and pylorus. Yes, which supplies the posterior aspect of body and the pylorus. Right. Now, why should I know about the nerve supply? Is because whenever a patient comes with severe duodenal ulcers or peptic ulcer, right, doctors usually they do vagotomy, right? So they're going to cut the nerve supply so that the impulses are not going to travel and cause gastric irritation. So what they do is they usually do something called as truncal vagotomy. They do something called truncal vagotomy. So when they do truncal vagotomy, again from the term it is very self-explanatory that they are going to cut the trunks, that is the anterior and the posterior vagal trunks, right? So if they are going to cut the anterior and the posterior vagal trunk, the entire nerve supply is going to be stopped. Now this gave lots of complications or worry to the patient. What is that complication? See, just now we saw the nerve of letter jet, right? The anterior nerve of the letter jet is going to supply the pylorus. So pylorus, as you have got the pyloric sphincter. So the sphincter, what it usually does, it does gastric emptying. So whatever contents are there in the stomach is going to be emptied into the duodenum. So the gastric emptying is predominantly taken up by the pylorus. So if I do a vagotomy right here, the pylorus innervation is affected. So whatever substance I am going to give to the stomach is going to stay there. So it is going to cause even more complications. Why it is complications? Because of delaying of gastric emptying. So what they thought, why can't I control the ulcer by just reducing the secretions? Because ulcer is because of HCl, right? So why if I target the gastric glands and probably cut the nerves there alone? Yes, that is called as highly selective vagotomy. So where they identify the gastric branches which supply the gastric glands and they just cut that branches alone. So because of this advantage, what happened is the anterior nerve of letter jet was not disturbed. So the gastric emptying was not delayed. Oh, you will get an idea of doing a highly selective vagotomy only if you know nerve supply of stomach. So you should know, yes, there is something called nerve of letter jet that supplies the pylorus. So if I disturb the pylorus, gastric emptying is delayed. So it leads to further complication. So I should think of a procedure wherein I just try to cut the gastric branches alone, the branches that supply the glands alone. Yes, that is called highly selective vagotomy. Yes, so this is about stomach. So I hope I made things clear, I made things simple. If you have any other doubts, you can probably ask me. It's a very simple topic, right? You just have to know how to get a note towards it, right? So if you're just going to listen to the session, I hope you will not have any difficulties in remembering things. I hope it is going to be easy for you. So thank you all. Meet you in some other video. Until then, take care. Tata. Bye.